The HIV/AIDS epidemic gained attention as a public health issue in the middle of 1980s. By the time the first count was taken in 1991, the population of adult Nigerians said to have been living with the virus was put at 1.8%. The figure grew to 3.8% 2 years later, but by 1999, the prevalence rate had jumped to 4.5%, a tipping point in epidemiology.
APIN started when nobody was operating in the HIV sector.
The whole concept of APIN started as a project of the Harvard School of Public Health through a grant that Phyllis Kanki got from Bill and Melinda Gates Foundation in 2000.
That grant actually was called AIDS Prevention Initiative in Nigeria. We wanted to set up a program that would develop evidence-based prevention programs. For HIV, we wanted to work with different arms of the government in health and also various universities.
In 1997, me and Professor Sage, we didn't know what to do with our pregnant women who were having HIV, how to prevent them from transferring the disease to their children. We started some work looking at STIs, diagnosing STIs and treating them, but there were no drugs. It was like a death sentence.
At the time, there was a poor appreciation of what was the real problem with the epidemic in Africa. There was perhaps some recognition that the epidemic was the most serious in southern Africa, but I think people still sort of had their heads in the sand about how bad the problem was.
And so even though they had tested positive at the time, were not put on treatment.
At the time, drugs were prohibitively expensive, and so most of Africa and Asia, where the large burden of disease was present, couldn't afford to buy drugs to treat their people.
For a long time, there was no treatment. So essentially what it means is there is a backlog, and there is a number which the government of Nigeria can actually cater for. So it was on quota basis, small out of. So the lower your CD4, the more you are able to get on the program. That was the situation then.
It was at this critical moment and context that APIN was born as a project of Harvard School of Public Health.
So it was an initial way to build capacity so that we'll be able to understand the disease and get health workers that are skilled to be able to provide service, and also build infrastructure like laboratories that could help in those services.
Fortunately for us, we had published some papers on HIV prevalence in pregnant women in the International Journal of Obstetrics and Gynecology. And the Harvard team saw the publication and they came looking for us here.
And during that time, we really developed programs that would look at prevention, and also we established an office in Abuja, previously having an office in Ibadan. And APIN as an organization of managers and administrative staff and financial staff was growing alongside of this grant project.
The system we use then is to actually contract, different groups in Nigeria, at the university, NGOs, who are working in one area or the other of HIV control.
We work mainly as a prevention organization company that is focused on HIV prevention then. And then with the advent of the PEPFAR program in 2004, we got sponsored by the US government through the Center for Disease Control to provide comprehensive HIV treatment and care services in Nigeria.
When we got the first funding from PEPFAR, still as Harvard School of Public Health, and with that we have helped to improve and increase the number of people who have been on treatment. At that time, most of the sites, I'll give an example, like Juth, had a slot for 750 patients only, whereas they had a waiting list of about 6,000. So what used to happen then was that people were praying for one patient to die so that somebody else could take But we've come a long way now.
Without APIN, I don't think we'll have any story to tell. Collaborating with Harvard School of Public Health, APIN has provided funding, provided training, and supported us all the way.
Before the program actually started, a lot of staff were trained. There were lots of training. The facilities were renovated. The HIV clinic was renovated. The laboratory was renovated. And the patients were coming and they felt at home, accessing their care. The usual, moving from one place to the other, like a UCH, which is a very big facility, was out of it.
What we do essentially is to provide logistic support that spans the whole value chain of laboratory development to help our treatment facilities to be able to provide diagnostic as well as monitoring capabilities for the labs that we're supposed to provide the highest standard as obtainable anywhere in the world.
It has also transferred technology to us. It has also built the capacity of our staff in terms of molecular diagnosis, in terms of CD4 count, and other specialized tests that hitherto were not available in the hospital. But now we can access such tests. And our own staff are the ones running that center.
Staff from nursing department, from medical record department, from laboratory department, and of course, the medical doctors were not left out. Also, nurses in the labor ward. We were well trained, I'm telling you, by APIN to make sure that we know what we are doing. And of course, the medical record department were also carried along in terms of good record keeping. And of course, they actually supported us in the area of health management information system. They actually trained the staff there.
There was a particular year we had well over 10 types of training, or 11. Everyone had the managerial level training, the field workers training, and the office-based M&E people. Everybody had hands-on training.
They don't compromise. They don't rush trainings. If, for example, a training is supposed to be for 10 days, APIN will do 10 days and make sure that people get what is expected of them. They try to get people who actually have the skill to do the work.
Indirectly, we are contributing to in-service training for laboratory personnel in the country. That is one impact. Then it's also impacting the people that are using the equipment. It's kind of made their life better or made their work easier because these are fully automated equipment.
To date, APIN has provided care and support to about 370,000 persons living with HIV, with more than 240,000 placed on antiretroviral drugs in over 2,000 clinics in more than 10 states across the country.
In 2004, President Bush announced the President's Emergency Plan for AIDS Relief. PEPFAR was a new program. They urged us to apply because we had experience in AIDS, both prevention and some treatment programs. And so Harvard applied with 3 countries. We had to apply with a minimum of 3 countries. We applied with Botswana, Tanzania, and Nigeria, with Nigeria being the largest component of our proposal. And we were awarded that.
We have succeeded with 3 additional grant cycles by the same US government between 2004 to 2008, 2008 to 2013, and 2013 to 2017.
But APIN had gone on from being a project of the Harvard School of Public Health to becoming the first fully comprehensive organization that is registered to work as a local entity.
When we were assessing them for the Global Fund project, at some point we went to the University Teaching Hospital in Jos, and we were very impressed with the quality of work done.
The beauty of it is APIN expands in your institution. they didn't really, the lab they had was not adequate to do the things we needed to do. And as their patient numbers increased, it was clear that that was not going to happen. So they had this old garage that was broken down. And then we renovated it and turned it into a lab.
Like State Hospital, Bumashaw, Jericho Specialist Hospital, Adeoyo Specialist Hospital, part of Rainwood, and Mania General Hospital, and I think some other hospitals. But these major ones, you could see that without the intervention of APIN, most of those laboratories will not have been able to provide adequate laboratory services.
We now established about 6 laboratories across the state and centers for tackling HIV issues and testing. Baricladi, Panshin, Jingri, Payam, and Ola.
So what we are trying to do now is that the service, the software service that has been provided here can be accessed by somebody at this third level without necessarily have to move. It's just the samples. So we also provide the mechanism for moving the samples from that primary level to secondary level, and from secondary level to the tertiary level.
In the past, we have only paper medical record system, but with the onset of APIN, we have electronic medical records, especially in the PEFA clinic, and that is what the hospital is now trying to imbibe.
Through electronic medical records that spanned all of the APIN run sites, we were able to study 77,000 people. There's no other study in the literature that studies numbers like that.
On August 30th in 2012, after clinic hours, a fire broke out in the APIN Lagos University Teaching Hospital. The next day, a canopy had been erected and patients were able to sit in another part of the clinic and still receive treatment. So there was really no interruption of services whatsoever. Emergency supplies and equipment were provided, and importantly, Luth was seeing thousands of patients for many, many years, and the records for all of those patients was preserved through our electronic medical record system. And so the program was really able to march on despite the loss of the physical structure of their clinic.
Working in over 1,000 health centers and clinics, and within communities, counseling and testing have been provided for more than 5 million people, including over 1 million pregnant women, out of which about more than 500,000 are provided with drugs to prevent mother-to-child transmission of HIV.
Before the intervention, so many mothers, have the risk of having babies that are HIV positive. But with the program, a lot of mothers have their babies and they are negative, so it's a lot of joy to them. And they are going to the community to, encourage people and to let them know that with HIV treatment and care, that the rates of transmission of the virus is greatly reduced.
They used to counsel us and advise us to tell our husband. That is many time. I now invite my husband from Lagos down to Badra and come and do his own test. And when my husband did his own, it's negative. So I disclosed my own. I disclosed my own to him and my children. We did my children that day. They are all negative too. So I've been helping me since 2000 during the counseling. So I've been using condom when we want to have another child. So we come for counseling during that time.
God keep me for a purpose, and with the help of the antiretroviral therapy that I'm taking. Okay. That's how you are seeing me now. Okay. Even as of, after that, I give birth to my last born, which is he's about 8 years now, and he's negative.
This is a complex type of program to provide treatment, and the treatment is lifelong. So it was really a difficult task.
APIN has supported our support group, and even our empowerment programs. Our patients and people who come, we say we want to teach you to fish, not giving you fish. So what do? How them is sewing. On graduation, they go with free sewing machine, knitting, computer, catering. We even have a youth soccer team. We have our own free elementary school that people can go at no cost.
I was not able to stand and talk to one or two people, but Faith Alive really helped me in that aspect. For me to talk and even gist with people, to train students, so much students as the ones that I have now.
We are making this. Yes, our madam is learning us to make this.
APIN has developed highly sophisticated partnerships nationwide, but more particularly in its 3 states of operation.
The AIDS Preventive Initiative of Nigeria have been updating, providing, and making sure state-of-the-art laboratory services is provided by for the people of Oyo State.
They have also supported us in the area of provision of certain equipment. I recall that in some of our general hospital and some other health centers, it is APIN that supported us to install the Gene Expert machines.
The good thing that they've done is that it's not limited to the center now. They have expanded. They have what we call satellite centers in almost the 17 local government areas of the state. And that has drastically, reduced the pain that patients go through in coming to this center in Jos.
At a stage, government officials thought we were coming to replace them, and they didn't want NGO, but there was a nice way. APIN brought the two of us together that we needed each other. We needed the facilities for referral, and they needed us to go to the community and mobilize clientele for them.
The most important thing about I like about what they are doing is that the sustainability of what has been on ground. And it ensures that it will outlive, even those of us that are here.
In 2016, APIN officially became APIN Public Health Initiatives.
APIN really grew as an NGO during that period. They became independent in 2007. We started to receive their own PEPFAR funding, and currently we just provide some technical assistance to them, and they run the show.
And as time went on, we felt that we could do other things. But we had this challenge that when we want to go for a grant for malaria, for instance, they say, oh, what's your AIDS prevention initiative in Nigeria? What gives us the confidence you could do this? And therefore it became, initially because the brand had been with us for a long time, we were very reluctant to change. But when we now saw the way the landscape was changing, we felt it was imperative that we change. And the other thing too is that even the patients, HIV patients, are living a lot longer now. And therefore they're also getting down with a lot of other non-communicable diseases like hypertension, diabetes. So the more we expand the scope of what we do, the more we can accommodate them to make them live long enough.
The infrastructural and organizational capacity it has built over the years has placed APIN in a position to understand the changing public health landscape in Nigeria.
We had, over the years, been able to build systems because our health relies on systems. And a system that addresses HIV program can address any public health intervention. So we felt that one was that we had the systems, we had the networks of communities, states, sites, we had the goodwill, we think, and therefore we just felt that we had the human resources, of course. Many of the people who work here are public health physicians who did not just train for HIV, but have the competency to do a lot of other things.
That is actually the direction of global health. And that is also the direction of Nigeria, because if you don't integrate, you can't be efficient. You can't, because if you go to the facilities today, the facility is not established to treat only HIV. They are there. The laboratory they have, we screen for malaria, we screen for HIV, we screen for TB, we screen for even cancer, we screen for diabetes. So why don't you integrate?
Why we change our name is that we want more, so that not just because we want to increase our portfolio, but more to increase the diversity of our portfolio.
APIN over the years has justified and has earned its due. So transforming now strictly from an HIV domain to a public health domain, I think is just what is necessary.